invite all the
Yes.
allow all delegates to.
I have started the webinar, so delegates can join, sir.
Okay. So good evening, everybody. I'm Sohan Solanki, and I, on behalf of SOAPC National, I welcome you all for the launch of this official journal of SOAPC. And now I invite Dr. Josna Goswami. She is the president of our SOAPC National, to take the proceedings further.
So thank you, Sohan, and good evening all. Today is a very special day. I am actually delighted and excited about the SOAPC journal. It was our actually long cherished dream which is coming true today, that the Journal of Onco-Anaesthesia and Perioperative Medicine, JOAPM, is now ready to launch. Thanks to Dr. Rakesh Garg, who is the editor-in-chief, for his determination and effort. It has been possible today, actually. And obviously, all of our best wishes and all was active for that. And for this great event today, we have two distinguished guests among us. Actually, three distinguished guests among us. One is Dr. Jiggy Divatia, who is head of the Department Anesthesia and Critical Care, Tata Memorial Hospital, Mumbai. Also, our past and first president of SOAPC. And then Dr. Sushma Bhatnagar, who is head Onco-Anaesthesia and Palliative Care, AIMS. And we have Dr. Chakrarao also today with us. So now I would request Dr. Sohan Solanki to continue further proceedings.
Thank you, madam. So I invite our first chief guest, Dr. J.V. Divatia, to say a few words. Sir, please.
Really a very big day for the Society of Onco-Anaesthesia and Perioperative Care. It has been a long cherished dream to have our own journal. And I think after a lot of hard work and a lot of perseverance and determination, we are now ready to launch the journal under the leadership of editor-in-chief, Dr. Rakesh Garg. So we've been having the Society of Onco-Anaesthesia and Perioperative Care, or SOAPC, has been very active in the past few years. Apart from our national conferences, we are now having daily online webinars, weekly online webinars, and a number of meetings across. We've had many new branches which are opening up. So I think Onco-Anaesthesia is an upcoming specialty. In fact, cancer surgery makes up for a large proportion of all anesthetics given all over India and probably the world, and it's only going to increase. And there is clearly a need for specialized knowledge and care in anesthesia and perioperative care for cancer patients. And this journal will, I think, fulfill this need, both for education and for research, because I think there'll be a lot of research which is going to happen in this field. And this journal will provide a platform for all of the researchers from India working in the field of anesthesia and perioperative care to showcase their work and publish their work. So I welcome this new journal, and I'm very excited, looking forward to the first issue. And I wish the journal all the very best, and I congratulate the leadership of SOAPC for making this possible. Thank you so much.
Thank you, sir. And now I invite Dr. Sushma Bhatnagar to say a few words. Madam, please.
So thank you, Sohan. So happy to see this day. We were first to give a word Onco-Anesthesia to anesthesia fraternity. And then we started courses in Onco-Anesthesia. And now we have learned that there are a lot of unanswered questions as far as cancer and anesthesia is concerned. And we all know that if scientifically we want to get the answer for anything in medicine, you have to do research. And once we will start having a journal of our own, then automatically the youngsters will start working on it, and they will start working on publishing their data, whatever small or big data they have, or whatever small new or new research they will do, they will publish it. And this will be the total, this will be the real contribution to the literature for whole of the world. And I'm really happy that finally, because last time when I met Dr. Jyotsna in one of a meeting, I think in Delhi, I and Sohan, I asked that what has happened to the journal. So they said that they are working on it, and so finally it is happening today, and I'm really happy. And this will be a big platform for our youngsters to publish their research, because now there are so many DNBs, so many fellowships will happen. So many our DM students, they do thesis every year. So we will motivate them to publish their thesis results in this on this platform. So I'm really happy, Sohan, Dr. Jyotsna, congratulations. Like so many things are happening in your tenure, and Dr. Divetya for having a vision of having this SOPSI like this. And we all are there to support whatever we can do from everyone. I think everyone is there to support, but I'm definitely can assure you that we will be there always to help and support this journal as well as this organization to grow as big as possible in this for whole of the world. Thank you very much, and congratulations once again.
Thank you, madam. So now I officially invite Dr. Divata sir and Bhattacharya madam to light the lamp and inaugurate our journal JOAPM.
Okay, how to light the lamp?
Madam, here it's for you.
Okay, I have touched this thing. I think, oh yeah. Okay, this flame is for me, and this is for Dr. Divetya, and this. And I think.
Thank you, madam.
So good to see this. I'm so happy.
Thank you, Dr. Bhattacharya. Yes, it needs a big clap for all of everybody actually.
So we can see almost 50 participants are there to celebrate this occasion.
Yeah.
And now I invite Dr. Rakesh Garg, our editor-in-chief of JOPM, to give the overview of this journal and how it is, how it will go further. Dr. Rakesh Garg, please.
Thank you so much, Dr. Sohan, and thank you, Madam Professor Sushma Bhatnagar and Dr. Divetya, and thank you, Jyotsna Madam, also for taking this lead and bringing out this journal, which will be dedicated to the Onco-Anaesthesiology platform. As Madam Dr. Sushma Bhatnagar mentioned, that Onco-Anaesthesia is the origin from India, and the speciality has emerged from India in this terminology, and so would be the journal, which is coming for the first time from our own country. So this will be a great boost. So thank you for launching this journal today, and we'll be going ahead, and this will be the official publication of Onco-Anesthesia and Perioperative Care. This journal will be publishing manuscripts which will be related into the field of onco-anesthesia, onco-critical care, pain, perioperative medicine, and palliative medicine. We'll be having 4 issues which will be published for this journal in a year. We have very robust editorial board member with us who will be running this journal, providing their experience in bringing out the robust scientific material for the researchers as well as the authors and readers to benefit and improve the care of onco-anesthesiology and perioperative medicine in not only in India but across the world also. And this is ably supported by the Society of Onco-Anesthesia and Perioperative Care and all the governing council members. And thank you, Dr. Jyotsna, Dr. Sohan, and Dr. Anjali, along with all the executive members who has been supporting this journal. Though it was delayed for some reasons, but finally it could see the face of its launch today. And these members have constructively put the efforts to bring this journal into the picture today. So I thank you so much for releasing this journal, and I officially invite all the members to submit their manuscripts. The online submission manuscript submission website is open for this journal, and everything is online, so this can be submitted online for all the manuscripts as per the scope we have mentioned. So thank you once again, and thank you all the participants also for listening, and please spread the word to others also so that they can submit their manuscripts to the journal. Thank you so much.
Thank you, Dr. Rakesh. So now we officially invite manuscript from all the member of SOPSI as well as the non-members also. So I end with this opening ceremony of JOAPM here, and I hand over to Dr. Jyotsna Garg and Dr. Jyotsna Goswami for the further proceeding of the webinar.
Okay. Thank you, Sohan.
Thank
This
you.
is a very nice experience from all of us. So again, I also will invite all the members and non-members to submit their manuscript for the journal, and it will be a great experience for all of us. Thank you so much to all this. So now we'll start
Thank you, madam.
the today's, yeah. So we can start the today's CME program, no?
Yes,
Yeah.
we can start now.
Okay. So now we'll start the today's CME program, and we'll all know that today's topic is anesthesia for thoracic surgery. And I invite the moderator for that. The moderator is Dr. Neha Desai. She is a senior consultant in my department, our hospital, and she is a thoracic anesthesiologist. Sohan? Okay. So her areas of interest is onco-anesthesia, thoracic anesthesia, GI, HPB, head neck surgery, and difficult airway. She is also the co-editor of the book, A Complete Guide to Onco-Anesthesia, Critical Care and Pain. Over to Neha, please.
Thank you. Kind introduction. So today's topic is anesthesia for lung surgery, which we know now has become very common as a part of onco-anesthesia, lung cancer coming up, and we are seeing the advent of so much minimally invasive and also non-intubated thoracic anesthesia. So I'll now invite my colleague, Dr. Rudranil Nandi, who's a consultant here at Tata Medical Center, to take us through anesthetic management of lung cancer. Can we have his CV on the screen, please? Yeah, so his areas of interest: anesthesia, postoperative pain, hemodynamic monitoring, cancer pain, palliative care. He's a co-editor with us, with Dr. Jyotsna and me, for our book, The Complete Guide to Onco-Anesthesia, Critical Care and Pain, and he has publications in various national and international journals and chapters in reports. So over to you, Rudranil.
Thank you, Neha ma'am, for your kind words, and thank you all SOPSI dignitaries and whoever present here, and also SOPSI members for giving me opportunity to talk about anesthesia for lung surgery. Please give me some time to share. Is it visible?
Yeah.
Is it visible to you, everybody?
It's visible, Rudranil, go ahead.
Yeah. So today's topic is anesthesia for lung surgery. So before coming into the anesthesia part, I'll cover my presentation will be like this. I will tell something about the epidemiology and the treatment of the lung cancer, followed by some relevant anatomy and physiology. And then we'll discuss about the preoperative assessment, then methods of lung isolation. Then we'll talk about the one lung ventilation, the anesthesia technique, the pain management modalities. Then we'll talk about about the fluid therapy and eras in lung surgery, post-operative complications, and at last we'll take about our experience in TMC. So as per the Globocon 2020 data, in India, lung cancer is the fourth most common cancer. In case of, irrespective of the patient is male or female. And in case of male, the lung cancer is the second most commonest cancer. Almost in a year, 72,000 new cases is occurring in India, and 66,000 patients are dying because of lung cancer. And so the data already showing that the 5-year survival rate is very poor in case of CA lung. But these 14% patients who have a 5-year survival rate, these are the patients basically who got the treatment of surgical excision. That means the curative, that means the resectable tumors those tumors which can be resected actually got the better survival. So our role as anesthesiologists in the perioperative period is very important, because we are contributing to this 14% of 5-year survival of this CA lung patient. So before starting into the details of the anesthesia, what patients we are usually getting, if we talk about the stages of lung cancer, it is basically it has basically the 4 stage. In stage 1, the tumor is less than 3 centimeter. In stage 2, the tumor is less than 66 centimeter, but it is eventually restricted to the lungs. But when the tumor is metastasized to the regional lymph nodes and the tumor is more than 6 centimeter, then it becomes stage 3. And when it has a distant metastasis, then it becomes the stage 4 disease. So in case of non-small cell lung cancer, which usually contributes to the 85% of the cancer, and small cell lung cancer, which contributes to the 15% of the lung cancer, that small cell lung cancer are usually treated with chemotherapy and the radiotherapy, and non-small cell lung cancer with stage 1 and stage 2, these patients usually underwent surgical resection, and we can see that the survival rate, 5-year survival rate, is quite high in this group of patients. So what are the different types of surgery we encounter? If any part of the lobe, we know that the right lung has 3 lobes, upper lobe, middle lobe, and the lower lobe, and the left lung has an upper lobe. Whole lobe can be removed. In that case, it will be called as lobectomy. The whole lung, if it is removed, it will be called as pneumonectomy. Some part of the lung tissue can be removed, especially it is done in case of say CA rectum, CA colon, CA RCC with lung metastasis, with solitary lung metastasis. In those cases, metastatectomy is done by wedge resection. Also, one bronchopulmonary segment can be removed. We know that 2022 total 42 bronchopulmonary segments are there. So that segmentectomy also can be done. Now I'll come into the details of the anatomy, or the relevant anatomy which we should know. So the trachea is divided into the right and the left bronchus. Right mainstem bronchus is more vertical, and the diameter of the trachea is 19 millimeter. This is very important while choosing the outer diameter of the DLT. And this area, that is the 22 millimeter, the right mainstem bronchus, after from the carina, after going almost 22 millimeter, that means 2.2 centimeter, the opening of the right upper lobe bronchus comes. But in case of left mainstem bronchus, the division of the left upper lobe and the left lower lobe comes almost after 5 centimeter. So this is very important regarding the placement of the DLT, regarding the morphology of right DLT tube or left DLT tube. So this is very important anatomy, that 22 millimeter or 22 centimeter is there before we get a right upper lobe opening in the right mainstem bronchus. Another important is the narrowest part in the tracheobronchial lumen is the cricoid area, that is 17 millimeter in case of men and 13 millimeter in case of women. It is important because the outer diameter of an DLT tube usually is bigger than the normal tube. So we often may encounter resistance while passing the tube, especially in the subglottic area. That means this cricoid area. Another important relevant anatomy is the length from the angle of the mouth to the vocal cord is 15 centimeter, and from the vocal cord to carina is the 12 centimeter. This is important to see whether at what level we should fix the DLT tube, or to see the markings in the bronchial blockers. If definitely now we have fiber optic bronchoscope, but this anatomical knowledge will sometimes help us a lot. Now, if we see the bronchoscopic view of the anatomy, so this is the carina. This is how the carina looks like. Trachea comprises of different C-shaped cartilages, and these C-shaped cartilages are stays and on the anterior wall of the trachea. Posteriorly, there is no cartilage. Trachealis muscles are there. These trachealis muscles or the posterior part of the trachea, it is basically convex towards the lumen, and this is the concave towards the lumen. So basically the trachea is ovoid shaped. These trachealis muscles help us to diagnose or to detect whether that this is the right side or this is the right main stem bronchus, this is the left main stem bronchus. Now if we go into the more detailed part, this is the carina. If we go enter into the left main, this is basically the left main stem bronchus. But as we have told that the left main stem bronchus is almost 5 centimeter long. So from the carina, we can't see the bronchus intermedius part or the secondary carina. That is the where that left upper lobe and the left lower lobe is dividing. That we can't see usually from the normal carina level. Now, if we enter into the if we enter deeper, then we will get this is the basically secondary carina. This is the opening of the left upper lobe, and this is the opening of the left lower lobe. Sometimes we reach the secondary carina without identifying the primary carina or the carina, the main carina. We can see that the carina here in the trachea, it is from the 12 o'clock position to 6 o'clock position. But in left main stem bronchus, the secondary carina usually lies between the 3 o'clock to 9 o'clock position. So if we place a left-sided DLT tube, this anatomical knowledge will help us to see the proper placement of the left-sided DLT tube. So if a left-sided DLT tube is placed, and if we pass the fiber optic bronchoscope through the tracheal lumen and stays here, we can see that the left in the left main stem bronchus, the DLT tube is going and right main bronchus is free. If we push this, if we move this fiber optic bronchoscope further to this area, that means the open right bronchus area, here we can see the opening of the right main stem bronchus almost after 2 centimeters from the carina. And this is the opening of the right main stem bronchus. It has a specific property. It has 3 openings. This is the only divisions in the entire tracheobronchial tree where there is a 3 divisions, because there is a 3 lobes, and this division often call it a Mercedes-Benz sign. And if we push this, if we see this fiber optic bronchoscope, if we push it through the bronchial opening, then we can see this left main stem bronchus or the secondary carina. So this is all about the placement of left main stem, left-sided DLT. Now, if we see, so this is the, again we are at the carina, and we are now seeing the right main stem bronchus, and you can see in left main stem bronchus, we were not able to see any opening from the carina, but here we can easily see right upper lobe opening from the carina itself. So as it is very close to the carina. So, and what we have already discussed, that this right upper lobe opening is, there is a 3 opening, and this is often called the Mercedes-Benz sign. This is like this. So often this is called the Mercedes-Benz sign. Now, if we enter it further, then we can see the secondary carina of the right lung. That is the right middle lobe and right lower lobe. The division of the right middle lobe and that is right lower lobe. So, and again, if we place a right-sided DLT, then as the right upper lobe bronchial opening is almost within the 2 centimeter from the carina, so there is a change in the shape of the cup of the right sided DLT, and there is a opening through which, when we ventilate the right lung, the air will also go to the right upper lobe. Otherwise, if this opening will not there, then this right upper lobe becomes collapsed, and only right middle lobe and right dual lobe gets the ventilation. So again, for the correct positioning of the DLT, we should pass the fiber optic bronchoscope, and we should come out through the side opening or the Murphy's eye, you can tell, or right upper lobe opening for the right upper lobe, and we should able to see that 3 opening of the right upper lobe. Then only we can tell that the right sided DLT is properly placed. Now, coming into basics about the physiology. Now, we all know that the perfusion and both the perfusion and the ventilations are more at the level of the base and less at the level of the apex. As we can see that at the level of the apex, the alveolar pressure is more, and at least it is more than the pulmonary artery pressure and the pulmonary venous pressure. So gradually this is basically the amount of perfusion a lung gets. So as long as the segment, as long as we go down in the lungs, the amount of perfusion increases. Also, ventilation also increases when we come down from the upper part of the lung or the lung 1 to the 4, because in the zone 1, all those alveoli are already distended, but in lung 4, the alveoli are usually small and compliant. So at the bottom line, so that the lower part of the lungs gets better perfusion and better ventilation. Upper part of the lung gets lesser ventilation and the lesser perfusion. But this change of ventilation and perfusion is more extreme with perfusion. That means the upper part almost don't get any perfusion, and the lower part gets a huge amount of perfusion. But in case of ventilation, the upper part gets less amount of ventilation, but is not that much less like the perfusion, where almost upper part is almost perfusion less. So this change from lower to higher is more with the perfusion and less with the ventilation. So this ultimately leads to the non-dependent area, that is this upper part, non-dependent area, this becomes under perfused, because here ventilation is more, perfusion is less. So VQ becomes more than 1. And this dependent area, where ventilation is less and the perfusion is more, there VQ becomes, so this area becomes over-perfused. So this dependent area becomes over-perfused and VQ becomes less than 1. Now, if a patient is awake and lateral position, what happens? So when the patient from the upright position to lateral decubitus position, in upright position, this is basically a pressure volume curve. This is a S-shaped curve. This steeper part of the curve means small change in pressure will lead to larger change in volume. That means compliance is very good. And these two parts, this upper part and this lower part, here the compliance is poor. Here with greater amount of with larger amount of pressure change, volume changes is less. So in upright position, in the non-dependent area, it is usually stays in this non-compliant region, and the dependent area stays in this compliant region. But in case of lateral decubitus position, dependent lung stays here in this compliant region, and the non-dependent lung stays here. So in case of when a patient is awake and a patient is lateral position, the dependent alveoli is small and compliant. So the dependent lung basically becomes compliant, gets favor and gets better quality of ventilation. Also the perfusion is good. So VQ matching is maintained. It favors the dependent lung in ventilation and perfusion as well. So the dependent lungs gets better ventilation as well as better perfusion. But when the patient becomes anesthetized, there is a cephaloid movement of the intra-abdominal contents and relaxation of the intercostal muscles and other things. Chest wall becomes non-compliant, and which eventually leads to this shift of the lung in this compliance curve. So in awake, non-dependent lung was at the steeper at the peak of the compliance curve, and dependent lung were better compliant. But when the patient becomes anesthetized, non-dependent lung, in that lung where we are going to operate, that becomes good, that becomes compliant, and the dependent lung becomes non-compliant. So eventually, and this lung is eventually going to be collapsed by one lung ventilation, and the lung which gets ventilation during the one lung ventilation is basically non-compliant. So it eventually leads to VQ mismatching. So as the surgery started, and there is an open thorax, some amount of blood still is going to the non-dependent operative lung. So that amount of blood is coming back to circulation without getting oxygenated. So this is called the shunt fraction. This shunt fraction is foremost cause of having hypoxemia during the perioperative period. So our target is to reduce the shunt fraction. So there are some mechanisms or some automatic mechanisms through which this shunt fraction gets reduced. One is hypoxic pulmonary vasoconstriction. As the lung which is going to be operated or which is collapsed, that lung has hypoxia. So this hypoxia leads to pulmonary vasoconstriction. As a result, that lung is not getting the perfusion. Beside that also, the operative lung is also gets some surgical compression, which ultimately leads to reduction of the shunt fraction, and also another important, gravitational blood shift to dependent lung. So after the anesthesia or in the lateral position, usually the lower lung, the dependent lung gets 10% increase in cardiac output, and along with this hypoxic pulmonary vasoconstriction, gravitational increase in blood flow, and surgical compression, all eventually leads to bring down the shunt fraction to almost less than 10%. Now, coming into the preoperative assessment, this is one of the most important part of today's discussion. So till now, there are 3 guidelines we have seen in the last decade, and one is American College of Chest Physicians guideline in 2013, in 2010, another 2009. But all these guidelines are a bit old. I will talk about later about this. But yes, these are the guidelines which available now. Now, before going into the assessment, the age-old three-legged stool are used, or three-legged stool are used, where respiratory, mechanical function, lung parenchymal function, and cardiopulmonary interaction are seen. So respiratory mechanical function is seen. It's seen by the spirometry, the result of the spirometry, and from this result we get FEV1 FBC, and from that FEV1 FBC we can calculate predictive postoperative FEV1. So predictive postoperative FEV1 is basically the amount of FEV1 the patients can generate, or what will be the FEV1 after certain amount of lung will be resected out, and threshold for increased risk is less than 30 to 40%. So if the predicted postoperative FEV1 is less than 30 to 40%, probably the patient will not withstand that amount of lung resection, and we should ideally, that is increased risk surgery, and ideally we should not continue with that. Lung parenchymal function is basically see how the oxygenation is going on. This is as an independent marker, it is better than FEV1 because it eventually see whatever lung is there, how it is contributing in the oxygenation, and the threshold is also same. cardiopulmonary interaction, we can see these two functions are basically see how the lungs are working. But to get a proper oxygenation, we need the cardiac functions also. And this cardiopulmonary interaction we can see by different types of tests. Cardiopulmonary exercise testing is one of those, and threshold value is less than 15 ml per kg per minute. That means VO2 max, if the VO2 max is less than 15 ml per kg per minute, then probably the patients may have a difficulty in the post-operative period. So predicted post-operative FEV1 and DLCO, those who are practicing thoracic anesthesia, they are aware of it, that the right lung has total 22 segments and left lung is 20 segments. So if we are going to cut the right lower lobectomy, so the whatever FEV1 is there, we have to reduce, or we have to deduct the 29% of the FEV1 to get the predicted postoperative FEV1. That means if the right lower lung is not there after the surgery, the there will be 29% reduction of the FEV1. Now, these are some values which guides us whether we can go for a pneumonectomy, lobectomy, or what are the risks. So if the FEV1 is greater than 2 liter, or FEV1 is more than 80% of the predicted value, then these patients can withstand pneumonectomy. We should not see anything after if we get a value of FEV1 more than 80%. We should not investigate further. If FEV1 is more than 1.5 liter, a patient can directly go for lobectomy. But if the predicted postoperative FEV1 is 40% or less, then the mortality is almost 16 to 50%. If predicted postoperative FEV1 is 30%, then this mortality increases to 60%. So these type of patients we should not attempt for any pulmonary dissection. And if the predicted postoperative DLCO is less than 60%, then also mortality rate is almost 25%. So if this FEV1 or DLCO had some limitations, because the tumor, say if there is a tumor in the right upper lobe, probably that right upper lobe is not contributing to the ventilation or perfusions, or basically this right upper lobe was dead in the preoperative period. So even if we resect that right upper lobe, that will not probably affect the FEV1 or DLCO in the postoperative area. So how to know whether that part of the lungs where the tumor is functional or not? We do a radionuclide scanning or ventilation perfusion scanning. So in this, this is a report of ventilation perfusion scan, where we can see that in this picture, the left upper, this is the left, this is the right. So this upper and the middle portion is not almost getting any perfusion or the ventilation. So even if we resect it out, it will not contribute, it will not change the FEV1. So whatever FEV1 in the patient was there in the preoperative period, if we resect this amount, the FEV1 will be same, because these are not at all contributing to the ventilation or perfusion of the patient. Now, so we have done the two things, mechanical functions and the parenchymal functions. Now we will go into the cardiopulmonary interaction. But before going into the cardiopulmonary interaction tests, definitely all patients posted for the pulmonary dissection or pulmonary volume reduction surgery, the patient should undergo a cardiac evaluation if the RCRI is more than 2. If RCRI is more than 2, and if the RCRI more than 2, preoperative cardiac evaluation is must. And if, as per the AHA-ACC guideline, if any patient needs CABG or PCI, that should be done preoperatively, because if we do a preoperative CABG, the chances of AMI in the postoperative period reduced from 5.8% to 2.4%. So and mortality is also reduced. But the problem with preoperative PCI, preoperative PCI also can be done, but preoperative PCI, if we don't give the adequate amount of time for the dual antiplatelet drug, then there is a major risk of AMI and the stent thrombosis. Now, if we come into the cardiopulmonary, the tests which detects the cardiopulmonary interactions, how the cardiopulmonary interactions is. There are some high technology tests. This is the CPET, and some low technology test like stair climb test. In cardiopulmonary exercise testing, there is a software, there is a machine which ultimately tells you the VO2 max, that is the maximal oxygen consumption of the patient. And in stair climb test, these are the low technology tests. We basically see how much what amount of height the patient can climb. In 6-minute walk test, we see how much what is the distance of a patient can walk in a 6-minute. Shuttle walk test, a bit confusing, a bit, I must say, a bit in shuttle walk test, there is a gap between there is a 10-meter gap, and the patient is asked to walk between these 10-meter gap, and the speed usually increases with every shuttle, and that total amount of shuttle patient completed or the total amount the patient covered is usually seen. So what are the different relationships between the different assessment methods? So we can clinically see the METs, we can see the CPET, we can see the VO2 max in the CPET, we can see the distance covered by the 6-minute walk test, shuttle walk test, or the stair climbing test. But what are the relation between these? So one METs is equal to 3.5 ml per kg per minute. So basically, if in CPET you get a 14 ml per kg per minute, or in case of clinically, you can see that patient is able to gardening, raking leaves, so he or she is 4 METs. So probably his CPET value will be 14 ml per kg per minute. 22-meter stair climbing is almost equivalent to 5 flights of stairs and almost equivalent to VO2 max more than 20 ml per kg per meter square. If the patient can climb 9 to 10 meter on the stair climbing, so probably he or she is climbing 2 flights of stairs, and it is almost like the VO2 max of 12 to 14. If the patient is able to walk for 400 meter 6-minute walk test, then VO2 max is like 15 ml per kg minute. And if 250 ml shuttle walk test is almost like VO2 max of 10 ml per kg minute. So the threshold value for high risk pulmonary resection for CPET, if it is more than 15 ml per kg per minute, you can go ahead with the resection. For shuttle walk, for stair climbing test, it is more than 20 meter. For shuttle walk test or the 6-minute walk test, if the patient can cover a distance of 400 meter, then probably it is going to be a very low risk pulmonary resection. Now, how to assess these patients? So this is basically an algorithm. So first I have to see the functional capacity of the patient. If the functional capacity is more than 2 METs, or it can be less than 2 METs. If it is more than 2 METs, we have to do the spirometry, and we have to calculate predicted postoperative FEV1 and predicted postoperative DLCO. If predicted postoperative FEV1 or predicted postoperative DLCO both is greater than 60%, or it may be 60 to 30%, or it may be less than 30%. If it is more than 60%, then we should proceed with the scheduled pulmonary resection. If it is 60 to 30%, that means predicted postoperative FEV1 or DLCO is 30 to 60%, then simple exercise testing like 6-minute walk test we have to do. And 6-minute walk test, if it is more than 400 meter, we should proceed with a pulmonary resection. If in 6-minute walk test it is less than 400 meter, then we should go for cardiopulmonary exercise testing. And also, if the predicted postoperative FEV1 or predicted DLCO is less than 30%, then also we should do a cardiopulmonary exercise testing. Cardiopulmonary exercise testing, if VO2 max is greater than 10 ml per kg per minute, then it is an increased risk of scheduled pulmonary resection, or we can tell it a moderate risk. If the VO2 max is less than 10 ml per kg per minute, or if the functional capacity was less than 2 minutes, and if the patient's functional capacity was less than 2 minutes, then also we should go or defer for medical consultation and optimization. And if the VO2 max is less than 10, then also we should defer the surgery for medical consultation and optimization. And after that, if there is nothing to be, there is nothing irreversible, then we should call it a high risk for scheduled pulmonary resection. Now, this is a very, as we have seen that this is all these guidelines are very old. So one editorial had been published whether this preoperative assessment for the minimally invasive lung surgery need an update. Definitely, because all these surgeries are, all these guidelines and surgeries are done almost 10-15 years back. Now the VATS and RATS, robotic assisted surgery, has come with an improved outcome, but for the last 10 years, there is no change in the preoperative assessment. Basically, whatever we were telling about the VO2 max or the correlation between the VO2 max and the postoperative complications, all these thoracotomies are done between 1985 to 2004. And more importantly, recent studies are telling the ACCP guideline is followed by only 0.5% of the surgeons. So wider lung parenchymal resections than preoperatively planned. That means as per the predicted FEV1 result, CPET result, whatever preoperatively planned, if you do the surgery with VATS, probably wider lung parenchymal resections can be used, and more patients may get a curative surgery options. So this probably now it has come to change this guideline, because all these guidelines are almost 10 to 12 years old. Now, coming into the methods of lung isolation, these are the there are basically two types of lung isolation: DLT and the bronchial blockers. We all know that the DLT gives excellent isolation, but definitely it is difficult to place, and as the diameter is large, so there is a chance of tracheal cup or tracheobronchial injury. In case of bronchial blockers, it has usually it is placed through the single lumen tube, and bronchial blockers are placed in one of the bronchuses, and no need to change the tubes before extubation, but definitely there will be a chances of dislodgement or loss of seal, and one lung to two lungs sometimes becomes difficult. So there are two types of DLT. In the right-sided DLT, there is a special lumen for the right upper lobe. The left-sided DLT is like that. There is a tracheal lumen, there is a bronchial lumen, there is a tracheal cup and the bronchial cup. So these are the normal things. Now, how to decide the size? So basically, this is I have taken from the Miller's anesthesia. So if a female, usually 35-37, and male 39-41, if the depending upon the height. If the height is less than 170, in case of male, it is 39. If it is more than 170, in case of it is 41. But in case of Indian male, we hardly use 41 size tube. In our institute in TMC Kolkata, we usually place 37 and 39 for the male, and 35 and 37 for the female. And if any patient is very much very short heighted, then 32 French tube is also placed. So I will not come into the details of the DLT placement or the confirmation. So after DLT, we can talk about blockers. So blockers are basically blockers. We can the bronchial blockers may come with a single lumen tube. It may come as independent. So in univen tube, bronchial blocker comes with single lumen tube, and in independent blocker it may be wire guided. ARN blocker is a wire guided blocker. Torque control blocker is the Kubdek blocker, Fuji blocker, and Cohen blocker. In Cohen blocker there is a circular knob which will help to place the bronchial blocker to the desired bronchus. And EZ blocker, as the name suggests, it is easy to place. It has a two prongs. I'll show the picture. It has two prongs, and two prongs will enter into the two main stem bronchus. And depending on the requirement, we can inflate one blocker. So this is a univent tube with blocker. This is Cohen blocker, this is EZ blocker with two prongs, this is Arndt blocker, this is uni blocker. And we can see that the distance between this white channel and the cuff is almost 6 millimeter. This is important again whenever we place, if it is placed in the right upper lobe bronchus, as this is 6 millimeter and right mainstem bronchus is 20 millimeter, so it can able to block right upper lobe bronchus also. This is a Kupdeck blocker. This is again EZ blocker, and this is how it is placed. It enters into the carina. And all these torque controlled blockers are basically can move to the right or to the left, and through the fiber optic bronchoscopy we can place it into the desired place. All blockers are coming within this type of three-way connector. One is connected to the ventilation circuit. One port is for the fiber optic bronchoscope, and one port is for the bronchial blocker, and through this port usually it is attached to the endotracheal tube. Now, what are the different types of malpositions of bronchial blocker? So this bronchial blocker, this bronchial blocker can be in the trachea. This blocker can be in the trachea, that we can diagnose with the fiber optic bronchoscopy, and the patients will not able to, cannot able to ventilate. Both prongs of the EZ blocker can go into the same bronchus. In that case, we have to withdraw the endotracheal tube a little bit, then again push it down so that the two prongs go into the two sides of the bronchus. And this is another malposition where the bronchial blocker is a little bit deeper, which eventually lead to the opening of the right upper lobe bronchus. So if the bronchial blocker is placed like this, then and we are trying to collapse the right lung, this right upper lobe will not be collapsed. So this is a bronchoscopic view where we can see that this bronchial blocker is beyond the opening of the right upper lobe bronchus. So in this patient, the right upper lobe will still be ventilating, and right middle and the lower lobe will only be collapsed. Now, coming into the one lung ventilations, usually one lung ventilations, we start with an FiO2 of 1 after for the denitrogenation of the operative lung, and gradually we reduce the FiO2, and we try to reduce the FiO2 till the saturation is maintained above the 92%. So the least possible FiO2 to maintain a saturation of 92% is the target FiO2. Usually a low tidal volume is given, 6 ml per kg. Routine use of PEEP, recruitment maneuver. In case of hypoxemia, CPAP to the non-dependent lung, and permissive hypercapnia, almost a PSO2 of 55 to 60 is sometimes is allowed not to increase the tidal volume or cause volume trauma of the patient. Now, which in this article, they have told that only low tidal volume is not beneficial. The low tidal volume with an adequate PEEP, physiologically appropriate low tidal volume with adequate PEEP is beneficial. Otherwise, the VT was inversely related to the incidence of respiratory complications. That means if we use low VT, the respiratory complications will be more. If we use larger VT, and the respiratory complications are less. So this is basically a retrospective study of almost 1,000 patients. So the take home from this paper is that you should use the low low tidal volume, but that should be physiological and along with an adequate PEEP. Now, how can we reduce the perioperative hypoxemia? That is one of the common problem. How to reduce it? we should reduce the smoking, we should treat the patients with antibiotics, we should preoperatively do chest radiotherapy, we should use mucolytic agents, we should use bronchodilators. So these things will reduce, if we do it in the preoperative period, probably it will reduce the hypoxia during the one lung ventilation. So during one lung ventilation, usually we try to keep the ventilated lung at the level of this FRC level, because as long as the pulmonary vascular resistance increases, with the volume the pulmonary vascular resistance increases, and so the oxygenation will be lesser. So we should fix that amount of PEEP, which eventually help to keep the lung at the level of the FRC, because pulmonary vascular resistance is least at the level of the FRC. And during the establishment of one lung ventilation, or before the establishment of one lung ventilation, we should give either 100% oxygen or oxygen nitrous we can give, because in both cases there will be denitrogen, the lung collapse will be faster, because oxygen will be absorbed into the lungs, or if you use nitrous, that will also be absorbed. But if we use air oxygen, then the nitrogen will be there, and it will prevent from lung to collapse. Now, if there is in spite of doing all these things, if there is an intraoperative desaturation, we should immediately go to the two lung ventilation. And if there is gradual desaturation, then we should do it in this way. First, we should clear the airway of mucus secretions of the blood. Then we can increase the PEEP up to 10 centimeter H2O, increase the FiO2, then to 100%. Then even after that, if the oxygen saturation is not improving, intermittent lung recruitment maneuver can be done. Then even after that it is not done, we should check the position of the DLT or the blocker. If it is, because the blocker is very prone to be dislodged, it may come out, it may go in. Even after that, if the blocker or DLT position is also fine, then oxygen insufflation through the suction catheter to the non-ventilated lung should be done. If oxygen insufflation through suction catheter is not helpful, then we can give CPAP or high frequency oxygen or high frequency jet ventilation to the non-ventilated side. Even if after that the patient is not responding to, or the hypoxia is not correcting, and we are planning of pneumonectomy, then early clamping of the pulmonary artery can be done, or eventually the intermittent double lung ventilation we have to do. Now, there are different studies regarding whether PCB is good or the VCB is good. Eventually, there is no difference in the arterial oxygenation with the use of PCB or VCB. In elderly patients, PCB may have better oxygenation. Again, a recent study has published whether the VCB or the recent or a newer modes like pressure control ventilation, volume guaranteed, how is there any difference? No difference in the oxygenation, but definitely in PCB VG or pressure control mode with volume guaranteed, P peak, P mean pressure or the airway pressure becomes less. Now, coming into the anesthesia technique, we can give TIVA or we can give inhalational based. With TIVA, there may be less PONB, HPB may be unaffected. Inhalational based anesthesia, it may protect from the lung injury, no effect on oxygenation or less inflammatory response. But what the studies says, the studies says that initial few studies like in 2011, 2016, all the 2017, these studies are saying that the administration of the sevoflurane during lung resection surgery reduces the frequency of postoperative pulmonary complications and reduce both the systemic and the pulmonary inflammatory response. So complications are less and inflammatory response are less. Few studies are telling. Then again, some studies are telling there is no difference in the postoperative complication and long-term outcome between the TIVA and the inhalational. Now, a recent study in 2021 telling the propofol-based TIVA was associated with better prognosis. So basically, whatever the evidence is, we cannot tell that yes, propofol is good or tiva is good or inhalational is good. But yes, definitely inhalational anesthesia probably reduces inflammatory response, but that is whether that reducing inflammatory response is contributing to the postoperative complication, nobody knows. Again, if we talk about the tiva, the long-term oncological outcome, here in this study they have seen the 5-year survival rate. They are telling tiva is better, but again the evidence is not that robust that we should start using tiva or we should discard inhalational or vice versa based on the current evidence. Now coming into the pain management. So basically, we usually do a multimodal analgesia. Neuraxial blockade are usually preferred. In ERAS, they are telling paravertebral analgesia is almost equivalent to the epidural. Besides paravertebral and epidural, we can use combined spinal epidural. We can we use other peripheral nerve blocks like serratus anterior pain block, erector spiny block, intercostal nerve block. Non-opioids have a huge role. Gabapentinoids has also role because prevention of the post-thoracotomy pain. NMD antagonist in ERAS protocol, in ERAS they have mentioned ketamine as an analgesic method for thoracic surgery. In case of opioids, IV, intrathecal, epidural, all routes we can use. We can use morphine, phentermine in all 3 routes. So basically, this multimodal analgesia we should do. Chronic post-thoracotomy pain is again another very problematic. Almost 3 to 5% patients develop chronic post-thoracotomy pain. Usually it is defined if the pain persists even after more than 2 months. So if this chronic post-thoracotomy pain is there, then adding all those antidepressants, anti-lipidleptics will probably help. And this chronic post-thoracotomy pain is usually developed if there is a pain prior to surgery, if there is an open surgery, or the acute postoperative pain is not adequately treated. Now we are coming to the last part of our presentation. Now we'll talk something about the fluid therapy. So basically, if we do a standard fluid therapy, there should be should not be any hypervolemia, there should not be any hypovolemia. The goal-directed, if we do goal-directed fluid therapy, chances of hypervolemia, here chances of hypervolemia is a bit more. Chances of hypovolemia is also more. If we do goal-directed fluid therapy, chances of hypervolemia and hypervolemia less. If we do restricted fluid therapy, chances of hypovolemia more, but definitely there is a chance of optimized fluid. If we do liberal, then chances of optimized fluid therapy is there, and also hypervolemia is there. Basically, if we do a restrictive fluid therapy or hypovolemia is there, then that ultimately leads to hypoperfusion or organ dysfunction. If more, then it will lead to edema. Basically, total fluid balance we try to keep in first 24 hours less than 20 ml per kg. Crystalloids in intra less than 2 liter. And in first 24 hours post-op less than 3 liter, less than 2 liter intra, less than 3 liter first 24 hours. And colloids for the blood loss. Urine output more than 0.5 ml per kg per minute is unnecessary. Invasive monitoring to guide inotropes and the vasopressors, and early use of vasopressor or inotropes, not to give fluid boluses, because the concept of third space is not applicable in case of lungs. And if we give much fluid and along with the lung handle, it will eventually cause the pulmonary edema. Now, there are some studies also saying goal-directed fluid therapy is beneficial, though they are in an open thorax, in an open chest. The validity of stroke volume variations is questionable, but there are studies are publishing that SBB-guided fluid therapy is better, and esophageal Doppler-guided fluid therapy is better. So we have these are the some future aspects where we should look upon. Now, ERA Society has also published guidelines for the thoracic society, but I will not go into the details of the ERAs, only the particular thoracic portions. What they have mentioned in ERAs is they are telling to give a lung protective ventilation. Paravertebral block is almost equivalent analgesia to epidural anesthesia. Ketamine should be considered if there is pre-existing chronic pain. For atrial fibrillation prevention, they are telling to continue beta blockers. They are telling to give magnesium supplementation if there is a magnesium depleted patients. And for preoperatively, they are telling to give diltiazem. If not beta blocker, if not the patient is on beta blocker, then we can give diltiazem preoperatively and amiodarone postoperatively for patients at risk. If thoracotomy is required, muscle sparing technique should be performed. Otherwise, ERA Society is telling to do VATS or robotic assisted surgery. Intercostal muscle or nerve sparing techniques are recommended. VATS should be done in case of early stage of cancer. Routine application of external suction should be avoided. Digital drainage system, that all those Sanofi drainage system where you can change the suction pressure, that should be used. And chest tube should be removed even if the daily serous effusion of high volume, that means almost the daily serous effusion if is almost more than 450 ml or up to 450 ml, then also they are telling to remove the chest tube. I don't know how compliant we will be there in different hospitals. A single tube should be used instead of two suction catheter. A two definitely suction tube. And prophylactic mini tracheostomy we can use or we can consider. Now, one or two slides regarding post-operative complications. There are different type of complications: atelectasis, pneumonia, air leakages, mediastinal shift, lung torsion, pleural effusion, bronchopleural fistula, atrial fibrillation. But pulmonary complications is the most common complications, and pulmonary complications occurs almost 15 to 20%. That means atelectasis, pneumonia, pleural effusion, these things happens almost in 15 to 20% of all cases. And all the 3 to 4% mortality what happened to that lung resection surgery, all are almost because of pulmonary complications. More than 50% of the lung collapsed even after several hours after surgery. So often after the patient gets shifted into the ICU, we get a saturation of 99 to 1, probably some part of the lungs are collapsed and or atelectatic. So in this group of patients, we have to give CPAP, we have to give chest physiotherapy. If we are expecting that some amount of mucus is plugged in the tracheobronchial tree, we can do a fiber optic guided suctioning. And if anything is not responding, then intermittent mechanical ventilation. Along with this persistent atelectasis or this atelectasis, if persists, as the patients are already the immunocompromised, these patients are led to pneumonia, and almost in case of thoracotomy, almost 2.1 to 10% develops postoperative pneumonia. Cardiac complications are also common. Arrhythmia occurs in 15% patients, atrial fibrillation in 12%, EMI in 5%, pulmonary thromboembolism in 5% patients. In case of, I have already told, if there is an atrial fibrillation, beta blocker should be continued throughout the perioperative period. And if prophylactic doses given, for preoperative, diltiazem is preferred. For prophylactic in the postoperative period, amiodarone is preferred. Now I'm talk about what we practice in TMC Kolkata. In the last, I have seen the data of last 6 months in our hospitals. We have done 29 lung resection surgery in last 6 months from January to June. Majority are right upper lobectomy and metastatectomy. Almost different lobe, different sides are done. VATS are done. Mediastinoscopy are done. So VATS are done in 4 cases. Open thoracic surgery is 25. Preoperative mediastinoscopy was done in 8 patients. Mediastinoscopy they usually do in the preoperative period before attempting a lung resection to see whether any mediastinal lymph node is involved or not. If it is involved, and they then usually they don't proceed for lung resections. In any of the surgery, it was abandoned. Even after mediastinoscopy, no lymph node was found, and eventually the patient underwent lung resection surgery. Right-sided OLB was done in 14, left-sided OLB done in 15. If we say about the OLB strategies, DLT was placed in 14 patients, left-sided DLT 10, right-sided DLT 4, EZ blocker in 7 patients, Kupdeck blocker in 8 patients. We have a cohen blocker, but we don't use it because it is very costly. And all right upper lobectomy patients, we usually put DLT because in case of right upper lobectomy, if we put that blocker during handling, there is a huge chance of dislodgement of that blocker. Either it go in or either it go out. So in right upper lobectomy, usually we prefer DLT. In other cases, the attending surgeon and the anesthesiologist, they decide which to place. If we talk about the analgesia, epidural ropin fentanyl was epidural is commonly placed. Erector spiny block was placed in 3 patients, and those are the basically VATS surgery, and if continuous catheter was not given. One VATS patient gets IV analgesic, no regional anesthesia was given. Otherwise, epidural is the common technique. Through epidural, we give morphine. Recently, we give morphine more in 16 patients, and we give ropin fentanyl also. 3 patients out of these 25 patients, of epidural ropin or morphine received IV fentanyl infusion besides the epidural analgesia. Epidural morphine we usually give at 2.1 to 3 milligram per dose in 12 hourly. Sometimes it is given on only 1 or 2 cases 8 hourly. We have encountered itching as the most common side effect of epidural morphine. Hypotension we encountered less with epidural morphine. Many surgeons, many anesthesiologists often prefer this epidural morphine because of that, because epidural local anesthetic infusions, it causes hypotension and eventually a NORAD infusion. Some prefer not to give NORAD infusion. So in those cases, epidural morphine is beneficial. If there is a hypotension with ropin, usually ropin 0.2% with fentanyl 2 mics per ml is the usual dilution. But if there is a hypotension, we often reduce this concentration to 0.1%. We don't put CVP line for this lung resection surgery until medically indicated. Usually put 2 IV cannula, 1 arterial line. GDT or goal directed fluid therapy is not routine. Fluid management we usually do mostly towards restrictive. So this is the end of our my talk. This is the department. This is a quite old picture. So after that, some consultants have joined, but they are not in the picture. So that's all from my side.
Thank you, Rudranil, for that exhaustive talk. You covered almost everything about lung resection surgery, and you covered also our practice quite comprehensively. So as of now, there are 2 questions which I think you can address. One is there is any simple formula to calculate VO2 max from 6-minute walk test?
That I have told that almost 400 meter 6-minute walk test, almost it corresponds to 15 to 20 ml VO2 max.
Yeah.
That slide, yes, that slide. I can show again. So and next question, ma'am.
Then another question is, what is your practice and experience for open and minimally invasive surgery, epidural versus paravertebral versus facial plane block?
Paravertebral, we usually don't give, usually put epidural only. Yes, for videoscope, for VATS, definitely we recently are giving erector spiny block, but single shot usually we give. But mostly epidural is preferred because the pain is not probably
pain control is
probably will not be good with the facial plane blocks.
And any reason for using epidural morphine as a predominant technique?
Because what we have already told that hypotension becomes a problem in our hospital after giving local anesthetic infusions, and that's why we use. Besides that, the quality of analgesia, because of the hydrophilicity, probably the spread is good. That eventually
Yes.
leads to good quality of analgesia in epidural morphine. What we are actually
I
practicing.
think the biggest advantage is that for our surgeons also, and in the post-operative in the ICU, when there's no hypertension, it keeps everyone happy, and it has given good pain relief, because here the main advantage is a dermatomal incision. So you don't have very big incisions like abdominal surgery. So the pain relief is actually quite good with these epidural morphines. So unless there's severe itching, which the patient is not able to tolerate, we've seen decent, good results with epidural morphine. Another question is your preferred technique for OLV in 6 to 12-year-old child.
6 to 12-year-olds, and definitely bronchial blocker will be preferred technique.
Yeah.
So
there are some 12-year-olds, if they are big enough, if their weight and all, height and all is good, you get certain DLTs which are up to 26 French. So if the height of the child is, if it is applicable, we can use the smaller DLTs in these patients, or mostly we have to go with bronchial blockers. The blocker, if feasible, it can be put intraluminal, or we don't get too many pediatric cases, but we've done a couple of cases where the bronchial blocker was placed extraluminally. So the blocker is passed outside the tube and the bronchoscope through the tube, and then that has been facilitated. So extraluminal bronchial blockers can also be used in small children if you don't have a very small scope to manage passage of both through the tube. The next question is, mention your choice of post-op analgesia when aspirin cannot be stopped, if patients are on dual antiplatelet therapy.
then the only option is the IV opioid.
Again, if it's just plain aspirin, and there are a lot of patients,
with only
older
aspirin,
patients
so
who
we
come
can
with prophylactic aspirin, we continue with the, we do give epidurals in those patients. And if they're on dual antiplatelet therapy, and if clopidogrel has stopped, usually even the ASTRA guidelines do mention that epidural can be given if it has been stopped in adequate time. So unless there's any other reason to avoid it, only then we avoid it.
Another question.
How frequently do you use the epidural morphine, and in what doses?
That almost in 16 patients out of 25, we use epidural morphine. So almost more than 60%. And what doses? 2.1 milligram to 3 milligram we use, and usually BD dose, 12 hourly.
So I think a patient profile also dictates how we select patient, either for morphine or for the infusions. Older patients, more comorbidities, frail patients, we tend to give plain epidural morphines to avoid the hypertensive effects. Otherwise, younger patients and who are otherwise fit, we do give infusions for these patients. There's next question about how do we handle post-operative air leaks. So yes, for all lung surgery patients, we use the Sinapi drain, which is a negative pressure drainage. And that is used for all the lung patients, and that is
also recommended by IRAS also, that digital that drainage system. Any experience, Aaron ma'am, in routine single lumen ETT placed endobronchial? No.
No,
ETT
pushing it endobronchial is an emergent situation. If you have hemoptysis or something and you need to absolutely isolate the two lungs, otherwise it's not something we would routinely do. So no. If 6-minute walk is less than 400 meters, how would you proceed?
If less than 400 meters, then ideally, as per the BA, we should do cardiopulmonary exercise testing, but definitely that is not done. So definitely that is a clinical decision, and you have to tease the APV1, the DLCO, then that you can do that radionuclide ventilation perfusion scanning. Based on that, we have to see all those things and decide. And the clinical, I think I personally believe the clinical, the effort tolerance of the patient is very important in this type of thing. If the patient's effort tolerance is good, probably the patients will withstand that thing.
And like Rudranil showed in the slides, all the recommendations and guidelines are older and mostly for open surgeries. And now a lot of recent evidence has come where minimally invasive surgery, where even patients with less than 40 predicted PPO-FEV1 have been operated and have had decent outcomes. So we should keep in mind that minimally invasive surgery has changed post-operative outcomes. So maybe it is time to change these cutoffs that we have.
All those guidelines are quite old, 10 12 years old, and all those guidelines are based on the open surgeries. So if we and probably if we follow strictly those guidelines, probably some patients we are actually we are not giving the benefit or chance of curative surgery. We are withholding that benefit to them, because in VATS and robotic surgery, they are telling that if we do a surgery what is more than planned, then also there is no complications.
That's true. No.
How long?
I think that is for epidural morphine.
We continue for 3 to 5 days. 3 to 5 days we usually continue. After that, sometimes it is more than that, but usually after 5 days we usually don't continue. Do you prefer direct measurement of internal dimension of the cricoid from CT scan to select the size of? Routinely, no. Or do you prefer the height-based formula in pills? Mostly height-based formula, but definitely if we have a history that the tumor may invading into the tracheobronchial tree, or there is a chance that it is not in the parenchyma or it is compressing, then definitely we see the CT scan and decide the size of the tube.
Next is, what is your hemoglobin threshold for transfusion in lung cancer surgery?
There is nothing separate for this, but definitely for if the patient is cardiovascular disease is there, then 10 or 9 or 10 should be the cutoff. But if the patient is otherwise okay, then 7 to 8 we usually. But
it's a routine, whatever we follow for others,
in other cases, and also not exactly the value. If the patient is requiring noradrenaline, NORAD support, patient symptom output is not that good. All those, if the patient is tachycardic, and we are expecting all those things come into the picture, and ultimately making decisions of the whether we transfuse or not. NORAD support is one of the important I must say indicator to guide whether we want to transfuse or not.
Generally, our rate of transfusion in lung surgeries is very low. So almost very little. Unless there's complicated surgery, the tumor is stuck and there's a lot of bleeding. But routinely, we don't give.
Sir, any experience with measuring USG-based outer tracheal diameter for DLT size? No, usually we don't do the outer tracheal. Usually it is not needed also. So tracheal diameter is almost 19 millimeter, and the almost if you see the 39 French or 41, it is almost the external diameter is 13 or 12, 13 millimeter. So usually it is not. We also don't do, but definitely with the advent of USG, you can see the tracheal diameter.
More than the tracheal diameter, it can be used to derive the left bronchial diameter to determine the DLT size if there is any doubt about insertion of a left DLT. So that's about the questions so far. That's in the chat box. That's it.
I think one person is asking that if the 6-minute walk is 6-minute walk test and VO2 max, probably
formula.
You can say 20 VO2 max, 15 VO2 max is equal to 400 meter. So from that you can 15, 20, 25 meter for 1 VO2 max. You can derive like that. probably
It's
that
not a
might be
very
confirmed.
validated thing because
It is
different
not very
studies have
validated,
reported
but yes,
different cutoffs, and there are certain studies where they have, just for research purpose, they've done both CPET and 6-minute walk test, and they have derived these complicated formulas to calculate the VO2 max. But routinely, we don't use any formula to select the
Why
VO2 max
that
from the
24 to 25 meter distance
Yes,
will almost lead to one VO2 max. So that 15 VO2 max is almost equivalent to 400. But that is a good actually predicted method, because this is the only method we can do. We don't have CPET now, so that is the only method we can use.
Yeah, that's right. Okay. So I think that's about that for the questions. Okay. Thank you, Rudrani. Jyotsa ma'am, would you like to put in some words?
Yeah, so all questions are answered.
Yeah,
No more
I've
questions, I
tried.
think.
No,
So it was a very good talk. I very covered almost every points, and I feel everybody is quite happy about the points you have covered. And Neha also moderated very well. I think all the questions are answered now. And anybody, any other questions to them? Otherwise, we'll call it a day.
Yeah, I think we can stop now.
So
Okay.
it was a good event
Thank you.
today. We had, I think, more than 75 attended today. We got a
Good.
store result.
Okay.
Congratulations, and also congratulations all for our news journal. So at JOAPM. So I hope that we will all send articles to this journal now.
Okay.
Yeah.
Good. So we'll call it a day. Thank you, Rudrani. Thank you, Neha.
Rudrani and Neha, it was wonderful Rudrani, wonderful presentation, and Neha, you have
Very good.
moderated it so well.
Thank you, ma'am. Thank you so much.
Thank you, ma'am.
Yeah.
Thank you, ma'am.
Okay.
Thank you,
Thank you.
Dr. Sohan.
Thank you.
Okay.
Thank you, Dr. Sushma. Thank you, everyone. Thank you, Sohan. Thank you, everyone. Okay. Good night then.
Thank
Yeah.
you. Thank
Thank
you
you,
so
ma'am.
much
Thank you,
to
Dr.
all of
Sohan.
you. And with all due permissions, I'm closing the session here and
Yes.
looking forward to hosting you again. Thank you so much. Take care.
Thank you.